Welcome to This Week in Medicine, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Medicine has you covered. Our AI-generated podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the medicine field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Medicine, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine. Hi, This Week in Medicine. We will start with the article from Journal of American Medical Association. Health Equity Adjustment and Hospital Performance in the Medicare Value-Based Purchasing Program. Importance: Medicare's Hospital Value-Based Purchasing, HVBP, program will provide a health equity adjustment, HEA, to hospitals that have greater proportions of patients duly eligible for Medicare and Medicaid and that offer high-quality care beginning in fiscal year 2026. However, which hospitals will benefit most from this policy change and to what extent are unknown. Objective: to estimate potential changes in hospital performance after HEA and examine hospital patient mix, structural, and geographic characteristics associated with receipt of increased payments. Main outcomes and measures: reclassification of HVBP bonus or penalty status and changes in payment adjustments across hospital characteristics. Results of 2,676 hospitals participating in the HVBP program in fiscal year 2021, 1,470, 54.9%, received bonuses and 1,206, 45.1%, received penalties. After HEA, 102 hospitals, 6.9%, were reclassified from bonus to penalty status, whereas 119, 9.9%, were reclassified from penalty to bonus status. At the hospital level, mean SD, HVBP payment adjustments decreased by $4,534, $90,033, after HEA, ranging from a maximum reduction of $1,014,276 to a maximum increase of $1,523,765. At the aggregate level, net positive changes in payment adjustments were largest among safety net hospitals, $28,971,708, and those caring for a higher proportion of Black patients, $15,468,445. The likelihood of experiencing increases in payment adjustments was significantly higher among safety net compared with non-safety net hospitals, 574 of 683, 84.0%, versus 709 of 1993, 35.6%. Adjusted rate ratio, ARR, 2.04, 95% C, 1.89 to 2.20. And high proportion Black hospitals compared with non-high proportion Black hospitals, 396 of 523, 75.7%, versus 887 of 2,153, 41.2%, ARR, 1.40, 95% C, 1.29 to 1.51. Rural hospitals, 374 of 612, 61.1%, versus 909 of 2064, 44.0%, ARR, 1.44, 95% C, 1.30 to 1.58, as well as those located in the South, 598 of 1,040, 57.5%, versus 192 of 439, 43.7%, ARR, 1.25, 95% C, 1.10 to 1.42, and in Medicaid expansion states, 801 of 1,651, 48.5%, versus 482 of 1,025, 47.0%, ARR, 1.16, 95% C, 1.06 to 1.28, were also more likely to experience increased payment adjustments after HEA compared with their urban, northeastern, and Medicaid non-expansion state counterparts, respectively. Conclusions and relevance: Medicare's implementation of HEA in the HVBP program will significantly reclassify hospital performance and redistribute program payments, with safety net and high-proportion Black hospitals benefiting most from this policy change. These findings suggest that HEA is an important strategy to ensure that value-based payment programs are more equitable. Provision of medications for self-managed abortion before and after the Dobbs v. Jackson Women's Health Organization decision. Importance: the Supreme Court decision in Dobbs v. Jackson Women's Health Organization overturned the right to choose abortion in the U.S., with at least 16 states subsequently implementing abortion bans or 6-week gestational limits. Prior research indicates that in the 6 months following Dobbs, approximately 360 fewer abortions were provided within the U.S. formal health care setting. However, trends in the provision of medications for self-managed abortion outside the formal health care setting have not been studied. Objective: to determine whether the provision of medications for self-managed abortion outside the formal health care setting increased in the 6 months after Dobbs. Design, setting, and participants: cross-sectional study using data from sources that provided abortion medications outside the formal health care setting to people in the U.S. between March 1 and December 31, 2022, including online telemedicine organizations, community networks, and online vendors. Using a hierarchical Bayesian model, we imputed missing values from sources not providing data. We estimated the change in provision of medications for self-managed abortion after the Dobbs decision. We then estimated actual use of these medications by accounting for the possibility that not all provided medications are used by recipients. Exposure: abortion restrictions following the Dobbs decision. Main outcomes and measures: provision and use of medications for a self-managed abortion. Results in the 6-month post-Dobbs period, July 1 to December 31, 2022, the total number of provisions of medications for self-managed abortion increased by 27,838, 95% credible interval, CRE, 26,374 to 29,175, versus what would have been expected based on pre-Dobbs levels. Excluding imputed data changes the results only slightly, 27,145, 95% CRE, 25,747 to 28,246. Accounting for non-use of medications, actual self-managed medication abortions increased by an estimated 26,055, 95% CRE, 24,739 to 27,245, versus what would have been expected had the Dobbs decision not occurred. Conclusions and relevance: provision of medications for self-managed abortions increased in the 6 months following the Dobbs decision. Results suggest that a substantial number of abortion seekers accessed services despite the implementation of state-level bans and restrictions. Next article from British Medical Journal: Use of progestogens and the risk of intracranial meningioma, National Case Control Study. Objective: to assess the risk of intracranial meningioma associated with the use of selected progestogens. Design: National Case Control Study. Setting: French National Health Data System, E-STEM National des Données de Santé. Participants of 108,366 women overall, 18,061 women living in France who had intracranial surgery for meningioma between January 1, 2009 and December 31, 2018. Restricted inclusion periods for intrauterine systems were deemed to be in the case group. Each case was matched to 5 controls for year of birth and area of residence, 9,305 controls. Main outcome measures: selected progestogens were used: progesterone, hydroxyprogesterone, dydrogesterone, medrogestone, medroxyprogesterone acetate, promegestone, dianogest, and intrauterine levonorgestrel. For each progestogen, use was defined by at least one dispensation within the year before the index date, within 3 years for 13.5 mg levonorgestrel intrauterine systems and 5 years for 52 mg. Conditional logistic regression was used to calculate odds ratio for each progestogen meningioma association. Results: mean age was 57.6 years, standard deviation 12.8. Analyses showed excess risk of meningioma with use of medrogestone, 42 exposed cases / 18,061 cases, 0.2%, V79 exposed controls / 9,305 controls, 0.1%, odds ratio 3.49, 95% confidence interval 2.38 to 5.10, medroxyprogesterone acetate, injectable, 9,18061, 0.05%, V11 9305, 0.01%, 5.55, 2.27 to 13.56, and promegestone, 83 18061, 0.5%, V225 9305, 0.2%, 2.39, 1.85 to 3.09. This excess risk was driven by prolonged use, greater than or equal to a year. Results showed no excess risk of intracranial meningioma for progesterone, dydrogesterone, or levonorgestrel intrauterine systems. No conclusions could be drawn concerning dienogest or hydroxyprogesterone because of the small number of individuals who received these drugs. A highly increased risk of meningioma was observed for cyproterone acetate, 891-18061, 4.9%, V256-9305, 0.3%, odds ratio 19.21, 95% confidence interval 16.61 to 22.22, nomogestral acetate, 925-18061, 5.1%, V1121-9305, 1.2%, 4.93, 4.50 to 5.41, and clomadanon acetate, 628-18061, 3.5%, V946-9305, 1.0%, 3.87, 3.48 to 4.30, which were used as positive controls for use. Conclusions: prolonged use of medrogestone, medroxyprogesterone acetate, and promegestone was found to increase the risk of intracranial meningioma. The increased risk associated with the use of injectable medroxyprogesterone acetate, a widely used contraceptive, and the safety of levonorgestrel intrauterine systems are important new findings. Next article from Journal of Clinical Oncology. International pooled analysis of leisure time physical activity and premenopausal breast cancer in women from 19 cohorts. Purpose: there is strong evidence that leisure time physical activity is protective against postmenopausal breast cancer risk, but the association with premenopausal breast cancer is less clear. The purpose of this study was to examine the association of physical activity with the risk of developing premenopausal breast cancer. Methods: we pooled individual-level data on self-reported leisure time physical activity across 19 cohort studies comprising 547,601 premenopausal women, with 10,231 incident cases of breast cancer. Multivariable Cox regression was used to estimate hazard ratios, HRs, and 95% Cs for associations of leisure time physical activity with breast cancer incidence. HRs for high versus low levels of activity were based on a comparison of risk at the 90th versus 10th percentiles of activity. We assessed the linearity of the relationship and examined subtype-specific associations and effect modification across strata of breast cancer risk factors, including adiposity. Results: over a median 11.5 years of follow-up, IQR 8.0 to 16.1 years, high versus low levels of leisure time physical activity were associated with a 6%, HR, 0.94, 95% C, 0.89 to 0.99, and a 10%, HR, 0.90, 95% C, 0.85 to 0.95, reduction in breast cancer risk, before and after adjustment for BMI, respectively. Tests of nonlinearity suggested an approximately linear relationship, nonlinearity equals 0.94. The inverse association was particularly strong for human epidermal growth factor receptor 2 enriched breast cancer, HR, 0.57, 95% C, 0.39 to 0.84, that equals 0.07. Associations did not vary significantly across strata of breast cancer risk factors, including subgroups of adiposity. Conclusion: this large, pooled analysis of cohort studies adds to evidence that engagement in higher levels of leisure time physical activity may lead to reduced premenopausal breast cancer risk. Next article from Journal of Hepatology. Characteristics and outcomes of immunotherapy-related liver injury in patients with hepatocellular carcinoma versus other advanced solid tumors. Background and aims. Immune-related liver injury, early, is commonly observed in patients with cancer treated with immune checkpoint inhibitors, ECs. We aim to compare the incidence, clinical characteristics, and outcomes of early between patients receiving ECs for hepatocellular carcinoma, HCC, versus other solid tumors. Methods. 2 separate cohorts were included, 375 patients with advanced/unresectable HCC, child PUA class treated with first-line atezolizumab plus bevacizumab from the ABREAL study, and a non-HCC cohort including 459 patients treated with first-line EC therapy from the NVIDIA-2 multicenter study. EARLY was defined as a treatment-related increase of aminotransferase levels after exclusion of alternative etiologies of liver injury. The incidence of early was adjusted for the duration of treatment exposure. Results. In patients with HCC, the incidence of any grade early was 11.4% over a median treatment exposure of 4.4 months, 95% C3.7 to 5.2, versus 2.6% in the NVIDIA-2 cohort over a median treatment exposure of 12.4 months, 95% C11.1 to 14.0. Exposure-adjusted incidence of any grade early was 22.1 per 100 patient years in patients with HCC and 2.1 per 100 patient years in patients with other solid tumors, p less than 0.001, with median time to early of 1.4 and 4.7 months, respectively. Among patients who developed early, systemic corticosteroids were administered in 16.3% of patients with HCC and 75.0% of those without HCC, p less than 0.001, and early resolution was observed in 72.1% and 58.3%, respectively, p equals 0.362. In patients with HCC, rates of hepatic decompensation and treatment discontinuation due to early were 7%. Grade 1 to 2 early was associated with improved overall survival only in patients with HCC, hazard ratio 0.53. 95% C 0.29 to 0.96. Conclusions. Despite higher incidence and earlier onset, early in patients with HCC is characterized by higher rates of remission and lower requirement for corticosteroid therapy versus early in other solid tumors, low risk of hepatic decompensation and treatment discontinuation, not negatively affecting oncological outcomes. Next article from Clinical Gastroenterology. Endoscopic removal of premalignant lesions reduces long-term colorectal cancer risk, results from the Japan Polyp study. Background and aims. To date, no regional evidence of long-term colorectal cancer, CRC, risk reduction after endoscopic premalignant lesion removal has been established. We aim to analyze this over a long-term follow-up evaluation. Methods. This was a prospective cohort study of participants from the Japan Polyp study conducted at 11 Japanese institutions. Participants underwent scheduled follow-up colonoscopies after a 2-round baseline colonoscopy process. The primary outcome was CRC incidence after randomization. The observed/expected ratio of CRC was calculated using data from the population-based Osaka Cancer Registry. Secondary outcomes were the incidence and characteristics of advanced neoplasia, and results. A total of 1,895 participants were analyzed. The mean number of follow-up colonoscopies in the median follow-up period were 2.8 years, range 1 to 15 years, and 6.1 years, range 0.8 to 11.9 years, 11,559.5 person-years, respectively. Overall, 4 patients, all males, developed CRCs during the study period. The observed/expected ratios for CRC in all participants, males and females, were as follows: 0.14, 86% reduction, 0.18 and 0, respectively, and 77 ONs were detected in 71 patients, 6.1 per 1,000 person-years. Of the 77 ONs detected, 31 lesions, 40.3%, were laterally spreading tumors, non-granular type. Non-polypoid colorectal neoplasms, NPCRNs, including flat, less than 10 mm, depressed, and laterally spreading, accounted for 59.7% of all detected ONs. Furthermore, 2 of the 4 CRCs corresponded to T1 NPCRNs. Conclusions. Endoscopic removal of premalignant lesions, including NPCRNs, effectively reduced CRC risk. More than half of metachronous ONs removed by surveillance colonoscopy were NPCRN. Nutritional assessment in patients after gastric electrical stimulation, GES background. Gastric electrical stimulation, GES, is used for patients with drug-refractory gastroparesis, GP, symptoms. Approximately two-thirds of patients with GP symptoms are either overweight or obese. We aim to assess symptoms and nutritional status pre-GES and post-GES placement in a large sample of drug-refractory GP patients. Methods. We conducted a chart review of 282 patients with drug-refractory GP who received temporary followed by permanent GES at an academic medical center. Gastrointestinal symptoms were collected by a traditional standardized PRO, 0 to 4, 0 being asymptomatic and 4 being worst symptoms, baseline nutritional status by BMI plus subjective global assessment, SGA score A, B, C, for mild, moderate, and severe nutritional deficits, ability to tolerate diet, enteral tube access, and parenteral therapy were assessed at baseline and after permanent GES placement. Results. Comparing baseline with permanent, GES was found to significantly improve upper GI symptoms in all quartiles. Of the 282 patients with baseline body mass index (BMI) information, 112, 40%, patients were severely malnourished at baseline, of which 36, 32%, patients' nutritional status improved after GES. Among all patients, 76, 68%, patients' nutritional status remained unchanged. Many patients with high BMI were malnourished by SGA. Conclusion. We conclude that symptomatic patients of different BMIs showed improvement in their GI symptoms irrespective of baseline nutritional status. Severely malnourished patients were found to have an improvement in their nutritional status after GES therapy. We conclude that BMI, even if high, is not by itself a contraindication for GES therapy for symptomatic patients. Next article from Journal of Infectious Diseases. Accumulation of immunity in heavy-tailed sexual contact network shapes mpox outbreak sizes. Many countries affected by the global outbreak of mpox in 2022 have observed a decline in cases. Our mathematical model accounting for heavy-tailed sexual partnership distributions suggests that mpox epidemics can hit the infection-derived herd immunity threshold and begin to decline, with less than 1% of sexually active men who have sex with men infected regardless of interventions or behavioral changes. We consistently found that many countries and U.S. states experienced an epidemic peak, with cumulative cases of around 0.1% to 0.5% among men who have sex with men. The observed decline in cases may not necessarily be attributable to interventions or behavioral changes primarily. Next article from Arthritis and Rheumatology. Risk of hypertensive disorders and preterm birth in pregnant women with systemic vasculitis, a nationwide population-based cohort study. Objective. Even though systemic vasculitis, SVs, affect primarily patients over 50 years of age, they can occur among women of childbearing age. Preterm birth, PTB, and hypertensive disorders are frequent complications of pregnancy in SVs. This study aims to evaluate the risk of hypertensive disorders and PTB among pregnant women with SVs, and to identify associated risk factors. Method. Using the French Health Insurance Data Warehouse, we conducted a nationwide cohort study including all pregnancies between 2013 and 2018 in women with SVs. These pregnancies were matched to pregnancies among women without SVs. We estimated risk of hypertensive disorders and PTB risk during pregnancy among women with SVs and investigated associated risk factors using a nested case control design. Results. Among 3,155,723 pregnancies, we identified 646 pregnancies in women with SVs, matched to 3,230 controls. SVs were significantly associated with hypertensive disorders, odds ratio, or 1.7, 95% confidence interval, 95% C, 1.3 to 2.2, and PTB, or 1.8, 95% C, 1.4 to 2.3. Chronic renal failure before pregnancy, history of or treated arterial hypertension, the occurrence of vasculitis flare during pregnancy, and the subgroup of SVs were independently associated with the occurrence of hypertensive disorders. Maternal age at delivery, chronic renal failure before conception, and the occurrence of vasculitis flare during pregnancy were independently associated with the occurrence of PTB. Conclusion: about 1 of 7 pregnancies in women with SVs is associated with hypertensive disorders or preterm birth. The occurrence of vasculitis flare was associated with these complications. Our findings support the importance of pre-pregnancy counseling to ensure disease stability. Next article from Circulation. Flip C-terminal ends of APOA1 promote ABCA1-dependent cholesterol efflux by small HDLs. Background: cholesterol efflux capacity (CEC) predicts cardiovascular disease independently of high-density lipoprotein (HDL) cholesterol levels. Isolated small HDL particles are potent promoters of macrophage sec by the ABCA1 ATP binding cassette transporter A1 pathway, but the underlying mechanisms are unclear. Methods: we used model system studies of reconstituted HDL and plasma from control and lecithin cholesterol acyltransferase LCAT deficient subjects to investigate the relationships among the sizes of HDL particles, the structure of APOA1, apolipoprotein A1, and the different particles, and the sex of plasma and isolated HDLs. Results: we quantified macrophage and ABCA1 sec of 4 distinct sizes of reconstituted HDL. Sec increased as particle size decreased. Tandem mass spectrometric analysis of chemically cross-linked peptides and molecular dynamic simulations of APOA1, the major protein of HDL, indicated that the mobility of C-terminus of that protein was markedly higher and flipped off the surface in the smallest particles. To explore the physiological relevance of the model system studies, we isolated HDL from LCAT-deficient subjects, whose small HDLs, like reconstituted HDLs, are discoidal and composed of APOA1, cholesterol, and phospholipid. Despite their very low plasma levels of HDL particles, these subjects had normal sec. In both the LCAT-deficient subjects and control subjects, the sec of isolated extra-small HDL, a mixture of extra-small and small HDL by calibrated ion mobility analysis, was 3 to 5-fold greater than that of the larger sizes of isolated HDL. Incubating LCAT-deficient plasma and control plasma with human LCAT converted extra-small and small HDL particles into larger particles, and it markedly inhibited sec. Conclusions: we present a mechanism for the enhanced sec of small HDLs. In smaller particles, the C-termini of the 2 antiparallel molecules of APOA1 are flipped off the lipid surface of HDL. This extended conformation allows them to engage with ABCA1. In contrast, the C-termini of larger HDLs are unable to interact productively with ABCA1 because they form a helical bundle that strongly adheres to the lipid on the particle. Enhanced sec, as seen with the smaller particles, predicts decreased cardiovascular disease risk. Thus, extra-small and small HDLs may be key mediators and indicators of the cardioprotective effects of HDL. Next article from American College of Cardiology. Revealing mechanisms and investigating efficacy of hemoadsorption for prevention of vasodilatory shock in cardiac surgery patients with infective endocarditis, remove. Description: the goal of the trial was to compare the safety and efficacy of an intraoperative hemoadsorption device for patients undergoing cardiac surgery for infective endocarditis, E. Study design: eligible patients were randomized in a 1-to-1 open-label fashion to either intraoperative hemoadsorption during cardiopulmonary bypass, CPB, using CytoSorb, N equals 138, or control, N equals 144. The hemoadsorption device was integrated into the CPB. Total screened, 740. Total number of enrollees, 282. Duration of follow-up, 30 days. Mean patient age, 69 years. Percentage female, 25%. Inclusion criteria: age greater than or equal to 18 years. E based on modified Duke criteria. Principal findings: the primary outcome, change in SOFA between hemoadsorption versus control compared with baseline, was 1.79 versus 1.93, p equals 0.67. Secondary outcomes for hemoadsorption versus control. 30-day mortality, 21% versus 22.4%, p equals 0.78. Postoperative stroke, 3.6% versus 2.1%, p equals 0.44. Hospital length of stay, 20 versus 19 days, p equals 0.39. Distributive shock, 68.1% versus 70.8%, p equals 0.70. At the end of CPB, median changes to baseline levels were greater in the hemoadsorption group than in the control group for the following inflammatory mediators: C. Terminal proendothelin 1, CT proet 1, minus 95.5 versus minus 26.8, p equals 0.01, mid-regional proadrenogulin, Mr. Proden, minus 0.5 versus 0.1, p less than 0.01. Role of transesophageal echocardiography, TE, and cardiac troponin, CTN, sensitivity and specificity of T to identify abscess correctly were 58% and 86%, respectively. The area under the curve, AUC, of high sensitivity, HS, CTNI for predicting abscess was 0.689, 95% confidence interval, C, 0.58 to 0.80, p equals 0.001, with an optimal cutoff according to the Uden index of 1.12-fold upper reference limit, URL, resulting in a sensitivity of 88.6% and a specificity of 44.9%. The AUC of HSCTNT for predicting abscess was 0.56, 95% C, 0.43 of 50.69, p equals 0.353, with an optimal cutoff according to the Uden index of 116.57-fold URL, resulting in a sensitivity of 34.5% and a specificity of 82%. Interpretation. The results of this trial indicate that, among patients with E undergoing cardiac surgery, intraoperative hemoadsorption using CytoSorb reduced some inflammatory cytokines postoperatively compared with control, but there was no change in clinical outcomes/organ dysfunction. This was a sick cohort. 30-day mortality was greater than 20%. Among patients with confirmed root abscess intraoperatively, adding preoperative HSCTNI but not HSCTNT values to T findings might improve cardiac abscess detection in patients with E. From Journals of the American College of Cardiology. Intraoperative anemia mediates sex disparity in operative mortality after coronary artery bypass grafting. Background: women undergoing coronary artery bypass grafting, CABG, have higher operative mortality than men. Objectives: the purpose of this study was to evaluate the relationship between intraoperative anemia, nadir intraoperative hematocrit, CABG operative mortality, and sex. Methods: this was a cohort study of 1,434,225 isolated primary CABG patients, 344,357 women, from the Society of Thoracic Surgeons Adult Cardiac Surgery Database, 2011 to 2022. The primary outcome was operative mortality. The attributable risk, R, the risk-adjusted strength of the association of female sex with CABG outcomes, for the primary outcome was calculated. Causal mediation analysis derived the total effect of female sex on operative mortality risk and the proportion of that effect mediated by intraoperative anemia. Results: women had lower median nadir intraoperative hematocrit, 22.0%, Q1 Q3, 20.0% to 25.0%, versus 27.0%, Q1 Q3, 24.0% to 30.0%, standardized mean difference 97.0%, than men. Women had higher operative mortality than men, 2.8% versus 1.7%, p less than 0.001, adjusted or 1.36, 95% C, 1.30 to 1.41. The R of female sex for operative mortality was 1.21, 95% C, 1.17 to 1.24. After adjusting for nadir intraoperative hematocrit, R was reduced by 43%, 1.12, 95% C, 1.09 to 1.16. Intraoperative anemia mediated 38.5% of the increased mortality risk associated with female sex, 95% C, 32.3% to 44.7%. Spline regression showed a stronger association between operative mortality and nadir intraoperative hematocrit at hematocrit values less than 22.0%, p less than 0.001. Conclusions. The association of female sex with increased CAB operative mortality is mediated to a large extent by intraoperative anemia. Avoiding nadir intraoperative hematocrit values below 22.0% may reduce sex differences in CAB operative mortality. Next article from Journal of Clinical Endocrinology and Metabolism. Structural and functional brain changes after glucocorticoid therapy in thyroid-associated ophthalmopathy. Objective: to investigate the brain structural and functional alterations in patients with thyroid-associated ophthalmopathy, (A.I.O), before and after glucocorticoid therapy, using voxel-based morphometry, (VBM), as well as resting state functional magnetic resonance imaging, (MRI), with amplitude of low-frequency fluctuation, ALFF, and regional homogeneity, REHO. Methods. Between 2019 and 2022, 32 patients with tau and 23 healthy controls underwent pre-therapy MRI in Nanjing, China. Intravenous glucocorticoid therapy was administered to all patients. At 3 months after end of therapy, 26 patients were available for rescanned MRI. VBM, ALFF, and REHO were used to evaluate the brain structural and functional differences. Results. Before therapy, tau patients showed significantly decreased gray matter volume, GMV, in the left orbital part of superior frontal gyrus, ORB-SUP, and medial superior frontal gyrus, SFGMD, than healthy controls. Patients had higher ALFF values in bilateral gyrus rectus and olfactory cortex and lower values in bilateral cuneus. Patients also showed decreased REHO values in bilateral lingual gyrus. After therapy, increased GMV in the left anterior cingulate gyrus and SFGMD, increased ALFF values in bilateral cuneus and superior occipital gyrus, and increased REHO values in bilateral SFGMD were found in tau patients compared to the pre-therapy cohort. Compared to controls, decreased GMV in left ORB-SUP was observed in post-therapy tau patients. Conclusion. Our results indicated that tau might cause functional and structural deficits in the visual and emotional regions of the brain, with recovery in the former and partial restoration in the latter after effective glucocorticoid therapy. These findings may lead to deeper understanding of the pathophysiological mechanism behind tau. Next article from Neurology. Sex differences in the role of multimorbidity on post-stroke disability, the Taiwan Stroke Registry. Background and objectives. Multimorbidity is common in patients who experience stroke. Less is known about the effect of specific multimorbidity patterns on long-term disability in patients with stroke. Furthermore, given the increased post-stroke disability frequently seen in female versus male patients, it is unknown whether multimorbidity has a similar association with disability in both sexes. We assess whether specific multimorbidity clusters were associated with greater long-term post-stroke disability burden overall and by sex. Methods. In the Taiwan Stroke Registry, an ongoing nationwide prospective registry, patients with first-ever ischemic stroke were enrolled. This analysis is restricted to those individuals surviving to at least 6 months post-stroke. Using a hierarchical clustering approach, clusters of pre-stroke multimorbidity were generated based on 16 risk factors. The algorithm identified 5 distinct clusters. The association between clusters and 12-month post-stroke disability, defined using the modified Rankin scale, MISS, was determined using logistic regression models, with additional models stratified by sex. The longitudinal association between multimorbidity and functional status change was assessed using mixed effects models. Results. 9,818 patients with first-ever ischemic stroke were included. The cluster with no risk factors was the reference, healthier risk group, N equals 1,373. Patients with a cluster profile of diabetes, peripheral artery disease, PAD, and chronic kidney disease, CKD, N equals 1882, had significantly greater disability, misses greater than or equal to 3, at 1 month, or 95% C, equals 1.36, 1.13 to 1.63, 3 months, or 95% C, equals 1.27, 1.04 to 1.55, and 6 months, or 95% C, equals 1.30, 1.06 to 1.59, but not at 12 months, or 95% C, equals 1.16, 0.95 to 1.42, then patients with a healthier risk factor profile. In the sex stratified analysis, the associations with this risk cluster remained consistent in male patients, or 95% C, equals 1.42, 1.06 to 1.89, at 12 months, who also had a higher comorbidity burden, but not in female patients, or 95% C, equals 0.95, 0.71 to 1.26, who had higher proportions of severe strokes and severe disability, P interaction equals 0.04. Discussion. Taiwanese patients with multimorbidity, specifically the concurrent presence of diabetes, PAD, and CKD, had higher odds of a worse functional outcome in the first 6 months post-stroke. Clusters of multimorbidity may be less informative for long-term disability in female patients. Further studies should evaluate other mechanisms for worse disability in female patients post-stroke. Next article from Chest. Do not resuscitate orders by COVID-19 status throughout the first year of the COVID-19 pandemic. Background. At the beginning of the COVID-19 pandemic, whether performing CPR on patients with COVID-19 would be effective or increase COVID-19 transmission to healthcare workers was unclear. Research question. Did the prevalence of do not resuscitate, DNR, orders by COVID-19 status change over the first year of the pandemic as risks such as COVID-19 transmission to healthcare workers improved? Study design and methods. This cross-sectional study assessed DNR orders for all adult patients admitted to ICUs at 2 academic medical centers in Chicago, Illinois, between April 2020 and April 2021. DNR orders by COVID-19 status were assessed using risk-adjusted mixed effects logistic regression and propensity score matching by patient severity of illness. Results. The study population of 3,070 critically ill patients were 46% Black, 53% male, with median age, interquartile range, IQR, 63, 50 to 73, years. 18% were COVID-19 positive and 27% had a DNR order. Black and Latinx patients had higher absolute rates of DNR orders than white patients, 30% versus 29% versus 23%, p equals 0.006. After adjustment for patient characteristics, illness severity, and hospital location, DNR orders were more likely in patients with COVID-19 in the non-propensity score matched, N equals 3070, AOR, 2.01, 95% C, 1.64 to 2.38, and propensity score matched, N equals 1118, AOR, 1.91, 95% C, 1.45 to 2.52, Cohorts. The prevalence of DNR orders remained higher for patients with COVID-19 than patients without COVID-19 during all months of the study period, difference in prevalence over time, p equals 0.751. Interpretation. In this multi-hospital study, DNR orders remained persistently higher for patients with COVID-19 versus patients without COVID-19 with similar severity of illness during the first year of the pandemic. The specific reasons why DNR orders remained persistently elevated for patients with COVID-19 should be assessed in future studies, because these changes may continue to affect COVID-19 patient care and outcomes. Exploring the association of male sex with adverse outcomes in severe bronchopulmonary dysplasia. Background. Bronchopulmonary dysplasia, BPD, is a significant contributor to morbidity and death in infants who are born premature. Male sex is an independent risk factor for the development of BPD. However, whether male sex is associated with adverse outcomes that occur after formal diagnosis of severe BPD prior to hospital discharge remains unclear. Research question. Is male sex associated with a higher risk of adverse outcomes in infants with established severe BPD? Study design and methods. A retrospective, Multicenter cohort study of infants enrolled in the BPD Collaborative Registry from January 1, 2015 to June 29, 2022 was performed. Demographics, clinical characteristics, and outcomes were stratified by sex, male versus female. Regression modeling was used to estimate the association of sex with the primary composite outcome of death or tracheostomy at hospital discharge. Results: we identified 1,156 infants with severe BPD, defined at 36 weeks post-menstrual age by the National Institutes of Health 2001 consensus definition. The cohort was predominantly male, 59% male infants, 41% female infants. However, rates of mechanical ventilation at 36 weeks post-menstrual age, type 2 severe BPD, did not differ by sex. Overall mortality rates within the cohort were low: male infants, 5.3%, female infants, 3.6%. The OR of death or tracheostomy for male to female infants was 1.0, 95% C, 0.7 to 1.5. Interpretation: our results lead us to speculate that, although sex is an important variable that contributes to the development and pathogenesis of severe BPD, it does not appear to be associated with adverse outcomes in this cohort of infants with established disease. The surprising results raise important questions surrounding the temporal role of biological sex in the development of severe BPD and its progression during the neonatal ICU stay. As we explore the phenotypes and endotypes of BPD, it is imperative to consider how sex modulates the disease from birth through hospital discharge. Next article from the American Journal of Respiratory and Critical Care Medicine. Lung Injury Prediction Model in Bone Marrow Transplantation, a Multicenter Cohort Study. Rationale: pulmonary complications contribute significantly to non-relapse mortality following hematopoietic stem cell transplantation, HCT. Identifying patients at high risk can help enroll such patients into clinical studies to better understand, prevent, and treat post-transplantation respiratory failure syndromes. Objectives: to develop and validate a prediction model to identify those at increased risk of acute respiratory failure after HCT. Methods: patients underwent HCT between January 1, 2019, and December 31, 2021, at one of three institutions. Those treated in Rochester, Minnesota, formed the derivation cohort, and those treated in Scottsdale, Arizona, or Jacksonville, Florida, formed the validation cohort. The primary outcome was the development of acute respiratory distress syndrome, ARDS, with secondary outcomes including the need for invasive mechanical ventilation, IMV, and/or non-invasive ventilation, NIV. Predictors were based on prior case control studies. Measurements and main results: of 2,450 patients undergoing stem cell transplantation, there were 1,718 hospitalizations, 888 patients, in the training cohort and 1,005 hospitalizations, 470 patients, in the test cohort. A 22-point model was developed, with 11 points from pre-hospital predictors and 11 points from post-transplantation or early, less than 24-hour, in-hospital predictors. The model performed well in predicting ARDS, see statistic, 0.905, 95% confidence interval, c. 0.870 to 0.941, and the need for IMV and/or NIV, see statistic, 0.863, 95% c. 0.828 to 0.898. The test cohort differed markedly in demographic, medical, and hematologic characteristics. The model also performed well in this setting in predicting ARDS, see statistic, 0.841, 95% c. 0.782 to 0.900, and the need for IMV and/or NIV, see statistic, 0.872, 95% c. 0.831 to 0.914. Conclusions: a novel prediction model incorporating data elements from the pre-transplantation, post-transplantation, and early in-hospital domains can reliably predict the development of post-HCT acute respiratory failure. Next article is from Clinical Journal of American Society of Nephrology. Time-varying determinants of graft failure in pediatric kidney transplantation in Europe. Background: Little is known about the time-varying determinants of kidney graft failure in children. Methods. We performed a retrospective study of primary pediatric kidney transplant recipients, younger than 18 years, from the Eurotransplant Registry, 1990 to 2020. Piecewise exponential additive mixed models were applied to analyze time-varying recipient, donor, and transplant risk factors. Primary outcome was death-censored graft failure. Results. We report on 4,528 kidney transplantations, of which 68% with deceased and 32% with living donor. 1,638 recipients experienced graft failure, and 168 died with a functioning graft. Between 2011 and 2020, the 5-year graft failure risk was 10% for deceased donor and 4% for living donor kidney transplant recipients. Risk of graft failure decreased fivefold from 1990 to 2020. The association between living donor transplantation and the lower risk of graft failure was strongest in the first month post-transplant, adjusted hazard ratio, 0.58, 95% confidence interval, 0.46 to 0.73, and remained statistically significant until 12 years post-transplant. Risk factors for graft failure in the first 2 years were deceased donor younger than 12 years or older than 46 years, potentially recurrent kidney disease, and panel-reactive antibody greater than 0%. Other determinants of graft failure included dialysis before transplantation, until 5 years post-transplant, human leukocyte antigen mismatch 2 to 4, 0 to 15 years post-transplant, human leukocyte antigen mismatch 5 to 6, 2 to 12 years post-transplant, and hemodialysis, 8 to 14 years post-transplant. Recipients older than 11 years at transplantation had a higher risk of graft failure 1 to 8 years post-transplant compared with other age groups, whereas young recipients had a lower risk throughout follow-up. Analysis of the combined effect of post-transplant time and recipient age showed a higher rate of graft failure during the first 5 years post-transplant in adolescents compared with young transplant recipients. In contrast to deceased donor younger than 12 years, deceased donor older than 46 years was consistently associated with a higher graft failure risk. Conclusions. We report a long-term inverse association between living donor kidney transplantation and the risk of graft failure. The determinants of graft failure varied with time. There was a significant cumulative effect of adolescence and time post-transplant. The ideal donor age window was dependent on time post-transplant. Trends and specific causes of cardiovascular mortality after kidney transplantation in Finland. Background. Cardiovascular diseases are an important cause of mortality in patients who have undergone kidney transplantation, but the knowledge on trends of cardiovascular mortality and specific causes of cardiovascular death among these patients is scarce. Methods. Our aim was to compare the cardiovascular mortality rates after kidney transplantation in Finland between 1990 to 1999, 2000 to 2009, and 2010 to 2019 using data from the Finnish Registry for Kidney Diseases. We analyzed 1-year and long-term cardiovascular mortality rates as well as the specific causes of cardiovascular death and the trends in them. Results. In total, 4,946 patients underwent first kidney transplantation in 1990 to 2019. During the follow-up time, median 8.3 years, interquartile range 4.0 to 14.5, there were 1,392 deaths, of which 582 were cardiovascular deaths. In an unadjusted Cox regression model, the risk of long-term cardiovascular mortality was similar in the different periods. However, when adjusted for age, sex, duration of dialysis, and cause of kidney disease, the long-term cardiovascular mortality risk was significantly lower in 2000 to 2009 and 2010 to 2019, hazard ratio 0.60, 95% confidence interval, 0.49 to 0.73, and hazard ratio 0.51, 95% confidence interval, 0.39 to 0.66, respectively, compared with 1990 to 1999. The results were similar regarding 1-year cardiovascular mortality. The distribution of different causes of cardiovascular death remained unchanged during the study period, with coronary artery disease accounting for 47% of deaths. During the first year after transplantation, pulmonary embolisms and arrhythmias were more common than in the long term. Conclusions. Cardiovascular disease remained the most common cause of death in kidney transplant recipients, but adjusted cardiovascular mortality risk has decreased significantly during the past 3 decades. Coronary artery disease was the most frequent cause of cardiovascular death, and the proportion of coronary artery disease-related cardiovascular deaths increased after the first year after transplantation. Next article is from Kidney International Reports. Familial variability of disease severity in adult patients with ADPT. Introduction. Autosomal dominant polycystic kidney disease, ADPT, is the most common monogenic nephropathy and has striking familial variability of disease severity. Methods. To better comprehend familial phenotypic variability, we analyzed clinical and pedigree data on 92 unrelated ADPT kindreds with greater than or equal to 2 affected individuals, N equals 292 from an Irish population. All probands underwent genetic sequencing. Age at onset of kidney failure, KF, decline in estimated glomerular filtration rate, EGFR, predicting renal outcome in polycystic kidney disease, PROPT, score, and imaging criteria were used to assess and grade disease severity as mild, intermediate, or severe. 1 mild and 1 severe case per family defined marked intrafamilial variability of disease severity. Results. Marked intrafamilial variability was observed in at least 13% of the 92 families, with a higher proportion of families carrying PKD1 non-truncating, PKD1-NT, variants. In families with greater than or equal to 2 members affected by KF, the average intrafamilial age difference was 7 years, and there was no observed difference in intrafamilial variability of age at KF between allelic groups. The pre-specified criteria showed marked familial variability in 7.7%, 8.4%, and 24% for age at KF, the PROPT score, and imaging criteria, respectively. In our multivariate mixed effects model, the intrafamilial variability in kidney survival was independent of the measured genotypic factors associated with prognosis and survival, p equals less than 0.001. Conclusion. Using objective measures, we quantified marked intrafamilial variability in ADPT disease phenotype in at least 13% of families. Our findings indicate that intrafamilial phenotypic variability remains incompletely understood and necessitates a more thorough identification of relevant clinical and genotypic factors. Thank you for listening to This Week in Medicine, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.